Let me just introduce myself again. My name is Andrei, and I'm a sixth-year medical student. Just recently, I've passed my internal medicine exam, and the reason I'm doing this lecture right now, or seminar, is that I thought maybe I could put some of the knowledge to good use. So this is going to be a seminar on the differential diagnosis of anemia. I will just do an overview. I won't go too much in detail because then, everybody will probably want to return back to their studies as well. And I guess if there's less information, then you retain more at the same time. If you have any sort of questions, you can stop me anytime and shoot. Also, so I mentioned this is going to be a seminar. From time to time, maybe I'll ask you for your input. There will be some questions, but nothing too hard or anything too, tough to answer. And at some point, I'll also be mentioning about like some clinical cases, but that's also going to be quite brief. All right. So let's get into it. This is the list of content. We're just going to be talking about the definitions, some important terms, a physio review. This is, I guess, pretty important for the third years. Then diagnosis and the diagnosis of anemia. This is important for everybody. Same with etiology, and then case reports. You guys that are in like third year, fourth year, or fifth year don't necessarily need to look at it, though. It could help you remember like in the long term. So first of all, let's just define anemia. Like, what is it? There's two important things that we need to remark. Well, the first one being that in anemia, we have a decreased RBC mass, red blood cell mass. And we can detect that in a patient by measuring their concentration of hemoglobin. We can also look at the hematocrit or the red blood cell count. So those are all together indices that will tell us whether the patient has a decreased RBC mass. And it's important to also determine whether the patient has or hasn't got any signs and symptoms of anemia. And we'll be talking about a little bit that a little bit later. Now, you'll see that in clinical medicine, they usually have multiple definitions for the same thing. And I just wanted to mention another one, that being that anemia could be defined as a decreased oxygen carrying capacity of the blood. But that could be a little bit tricky if you use that definition. You might be thinking, okay, if there's decreased oxygen carrying capacity, is there going to be a decreased saturation of oxygen, which is expressed in percentage, or will there be a decreased pressure, a partial pressure of oxygen in the arterial blood? And the answer to that is no, everything else is normal. So saturation of oxygen is normal, pressure, partial pressure of oxygen in the arterial blood is normal, which is why this definition is a little bit more tricky. I would recommend using the first one. Right, everything good? We gotta move on to a few important terms that I would like you guys to remember throughout the lecture. Namely, we have hematocrit. I mentioned it earlier in the definition. This is a decreased volume of sorry, not a decreased volume, but the definition of hematocrit is basically a percentage that the blood is made up of red blood cells. This is somewhere around 45 to 55%, depending on whether the patient is male or female. And so right here, you just have the formula of how it's calculated. We'll be using a lot also mean corpuscular volume. Corpuscular usually refers to like cell. So this is a fancy term. I would say it's a fancy term for cell, so mean cell volume. And this refers to the volume of one red blood cell. And so you'll see that anemias will be categorized into 3 different groups, depending on how much their volume is, or like how big they are. So you'll see later that we will have microcytic anemias, and that means that the volume of the cell is decreased. So you just have a smaller cell, and you can see that usually, or you can measure it by looking at a blood smear. Then you have microcytic, which means just the larger than normal cell. Another term that's important is red blood cell distribution width. It just means like you look at the microscope, you measure the red blood cell, and then you compare it with the size of other red blood cells, and that variance, how much they vary from one another, is the RDW. And then 2 terms that you might be seeing from time to time is anisocytosis, which means that the difference between 2 cells is high. Normally, most of the cells should be the same size, plus minus. However, in anisocytosis, most of the cells differ from one another. So that's quite abnormal. Then you have poikilocytosis, not as often used as anisocytosis, but it just means that, well, normally nothing is perfect, right? So you will be having a few abnormal cells, but that's all right, you know, like within a certain limits, obviously, that's all right. However, if there's too many of them, too many cells that are abnormal, that we call poikilocytosis. So anisocytosis, again, means that there is an increased variance in their size, and poikilocytosis just means that it's more than a certain percentage. Then, does everybody know about reticulocytes? They're just the precursors, so to speak, of red blood cells. And it's important to note that they're in peripheral blood, right? Not in, I mean, they could also be in the bone marrow. In hemato-oncology, you usually look at both the blood and what's inside the bone marrow. So it will be important for later on to be able to tell, okay, we find this in the blood, but not in the bone marrow. So reticulocytes, just immature red blood cells in peripheral blood. All right. So this is the time for like 3rd years to shine. Where are red blood cells produced?
Bone marrow.
Nice. And why do you think I just put that obvious fact there?
Well, it can have consequences, like if you have some tumor or like some malignancy in the bone marrow, that will definitely affect also the blood cells.
Precisely. Do you know what it's called when you have very few cells in the bone marrow? Like normally, let's say you have, this is a totally arbitrary term, you have 100 red blood cells in the bone marrow. Again, arbitrary term. But if you have like 10, you won't be producing almost anything, and you're at risk of death. What would you call this? It's just very few red blood cells, very few white blood cells, and very few megakaryocytes.
Pancytopenia? Like
Nice, exactly. That's it. Pancytopenia. And that's one of the etiologies for anemia, but not as common as others. But we'll get to it later. So some properties of red blood cell. Do they have a nucleus? No, they don't. The lifespan. Who knows the lifespan?
Under 20 days.
Yeah, nice. So non, and the lifespan is 120 days, correct? The importance of the lifespan is that normally in non-pathological conditions, the cells get to live a full 3 months. However, in some conditions, such as hemolytic anemias, they live less. You know, something happens to them, you know, an accident, they get murdered in the street. So their lifespan would be shortened. Then flexibility. Are they or are they not flexible?
Yes.
And why is that important?
So they can like go through the capillaries.
Nice. And now, what about some pathologies related to flexibility? Like, when would you say that the flexibility is decreased and that could potentially be a problem? For example, let's say that you have a problem with the cytoskeleton. Most of those problems are inherited, so you're born with it, or you get it from your parents. There's some sort of family history. And so you have a problem in the cytoskeleton. The red blood cells cannot squeeze through. They clump together, form a clot, and then you have two problems. But we'll talk about that later. The disease that's very commonly mentioned is sickle cell anemia. Volume, we talked about this in the definition earlier. And now basics of hemoglobin synthesis. I have a slide later on about how it looks like, the synthesis, the biochemical pathway. But other than that, I just wanted to make it clear that in adults, you have about 95% of this variant of hemoglobin called adult hemoglobin with 2 alpha, 2 beta chains of globin. Babies and fetuses, they have 2 alpha and 2 gamma. This is, again, important because let's say that your patient has a defective hemoglobin, like this one, adult hemoglobin. So you can give them some drugs and then that will increase fetal hemoglobin. And so if this one is affected, right, you just provide them with this other one, which is not affected. If it increases, that means that his symptoms get a little bit better. And that would also be like, for example, those inherited disorders like sickle cell anemia. But that's a little bit too detailed. This is differential diagnosis, so we'll just move on. Again, a little bit of, I guess this is more like biochemistry than physiology and pathophys, but let's look at it. So to make heme, you take this, I forgot the name of it. Can somebody help me out? No, I guess it was like something like, I kind of don't remember right now, but alpha levulinic acid or something like that. And this is the first product that you get. I think it's synthesized in the mitochondria. The steps of synthesis of heme take place in both the mitochondria and the cytoplasm. It's not important for us right now. What is important for us, though, is that if there's a defect here, then you can get anemias, and those are called porphyrias. When you have a disorder of the synthesis of hemoglobin, that's referred to as porphyrias. And then the next thing is that you have to incorporate iron into this protein, protoporphyrin, and you end up getting heme, or as it's spelled in English, heme. And you can see how if we have a deficiency of iron, we do not get enough heme, therefore we do not get enough hemoglobin and nothing to put in our red blood cells, which is why the volume will be slightly what? Increased, decreased, or normal?
Increased. Isn't it that like vegetarians often suffer from iron deficiency and they always also often have megaloblastic anemias?
That is correct, but megaloblastic anemia, we'll talk a little bit about it later. It will be due to a different deficiency, particularly of B12 or folate. And B12 and folate, they're involved with the synthesis of DNA. And so what happens is that if you have, let's say this, can you see like how I'm drawing here, sort of?
Yes.
Right, so if I have this red blood cell, and because I don't have enough DNA, I only get 2 instead of like 5 or 6. So what's the only way that I can make up for the absence of the extra red blood cells that I need? I pack them up with more iron, right? So what happens is that the megaloblastic cells will just get bigger as I pack them up with more iron, right? That's because we cannot afford to make more, but we can afford to put more iron in there. So that's why you get something that's called megaloblasts, big cells, right? But if we don't have enough iron, right? So those are the ones that are packed with irons, right? A lot of them. And if we don't have enough iron, but we have enough, I'm just gonna delete this for a second. If we don't have enough iron, but we have enough folate and B12, what happens is that we rather make more red blood cells, but they'll just be smaller because we pack them with like almost no iron. And so we have right here 3 small red blood cells, and they'll be called microcytic. They'll be part of microcytic anemias. 2 big cells, huge, megaloblasts. They'll be part of macrocytic red blood cells. And this is just, let's say this is a normal one. So this one on the left, huge, right, small, middle is normal. And that's what happens. So if we have no iron, it just means we get the smaller volume cell, microcytic anemia. Let me just delete it.
Okay, thank you.
And so this is why I'm mostly showing you guys the biochemical pathway of synthesis of hemoglobin. So we managed to successfully pack iron into protoporphyrin. We have enough of both, and we get heme. Now it's time to do what? Well, we take this and we put it into a protein with 4 subunits. This protein, globin, it's usually made up of 2 alpha and 2 beta chains in adults, right? We saw earlier that in fetuses and in neonates, you have a little bit of 2 alpha, 2 gamma. This is the gamma one is the different one. And so let's say now that everything was fine, but something is wrong with the globin. This is where something can go wrong if we have an inherited disease such as sickle cell anemia or thalassemia. But we'll talk a little bit more about it later. And so then again, you get fewer cells and or cells that are just more susceptible to damage. This picture on the right, I'm putting it here because you might need it at some point, is just how hemoglobin is released from the red cells and what happens to it afterwards. Next up is like, how do we diagnose anemia? Well, first of all, we have to ask the patient about their history, what they've been doing, eating, and so on and so forth. We'll talk about it a little bit later. Then signs and symptoms. Those are pretty important because that's how you can tell whether a patient, well, not you can't always be 100% sure that they have anemia, which is why you'll be carrying further investigations, such as we have to make sure that they're hydrated, because if they are dehydrated, it might seem like they have a lot of hemoglobin, a lot of red blood cells, but it just happens that they're dehydrated. You see how, like, if the volume increases, the concentration will decrease. Then we move on further to, this is a complete blood count. It's how they shortened, like in the US or the UK, the blood panel, complete blood count with differential. Differential means that we take a look at, for example, so you have in a complete blood count, you have usually red blood cells, white blood cells, and also platelets. Right, this is a complete blood count. If I put a differential, then that just means like they will tell me also what kind of white blood cells I have in there, how many of them are in there, percentages, and so on and so forth. So we will want that because it will aid us further with diagnosis in case it's not immediately obvious. And then reticulocytes and the blood smear. Those are pretty, I mean, everything is pretty damn important. This is the basics of diagnosing anemia. And we'll talk a little bit more about reticulocytes under, I think, hemolytic anemias. Blood smear is important throughout. You remember earlier I just mentioned that you have not megakaryocytes, but those megaloblasts in megaloblastic anemia, or that you have microcytic anemia where they're small. So this you can see on a blood smear. You take a little bit of blood from the periphery, spread it out nicely on a slide, then put it under the microscope. So those are the steps that you will be taking in the diagnosis in anemia. With regards to symptoms, everybody knows that a patient might report that he's feeling fatigued. He might be feeling, or she might be feeling weakness, lightheadedness. Some patient might report that they're feeling dizzy or that they've had fainting, but it's important to clarify that with the patient, whether it's lightheadedness, meaning that they're just feeling a little bit, well, how to put it, they need to take a rest, sit down a little bit and chill. Then there's decreased tolerance to exercise. There might be, later on, if anemia isn't treated, there might be dyspnea. Does anybody know what dyspnea is? I think there was a seminar on this last week, so in case you didn't check it out, might be worth checking it out, available on YouTube. Dyspnea, it just means like you're having difficulty breathing. It might be because you're truly having a difficulty breathing, or it just might be also psychological. Though this is not the purpose of this lecture, so we'll move on. And then syncope. You see, syncope is something that happens when there's not enough perfusion or not enough oxygen reaching the brain. And that can totally happen in case the patient is very anemic. All right. Oh, by the way, does anybody know the difference between symptoms and signs?
Symptoms are subjective while signs are objective.
Nice. So yeah, symptoms is what the patient will tell us. Wait, I have this, but I don't know. This was a nice, I have a nice animation. Let's see if I can change it up a little bit. All right, you can see my screen, right? You guys can see?
Yes.
All right. I just wanted to check with you guys. Anyway, so symptoms is what patients are telling us. Signs is what we as doctors identify and then necessarily put down on a medical notes and then share with our colleagues. So when it comes to anemia, we can easily divide it into a few subgroups, particularly ENT symptoms, ear, nose, and throat symptoms, cardiac, dermatological, and splenomegaly, and lymphadenopathy. One friend of mine, when I asked her how is she remembering all the signs and symptoms, told me that I should always start from the head and then go down, and then I'll focus on the general or first general and then head to toe, basically signs and symptoms. So that's why I'm starting with ear, nose and throat, going to cardiac, and then general. So in ENT, the first sign and symptom, the first sign you might see is pallor in the conjunctiva. This looks like this. This might be one of the first signs. Although we describe pallor in mucous membranes, we look usually at the conjunctiva, which is a mucous membrane, but it's the best seen there. Angular cheilitis, this is like mild inflammation around the angles of the mouth. And then in some cases, jaundice, which can also be seen in the conjunctiva or in the sclera. Cardiac, later on, if the patient doesn't treat his anemia or if the anemia gets worse, they might have tachycardia, and it might be associated with the orthostatic hypotension. Do you guys know in the third year what orthostatic hypotension is?
Yeah, we did it in physiology.
Nice. So when they basically stand up, they'll just they'll feel dizzy or lightheaded. Systolic flow murmur. This could be heard, but well, I can't really say that I've heard any thus far. Signs of chronic heart failure. This is quite late. Like the patient might be complaining of tiredness. They might be having water in their lungs. Well, not exactly water, but we'll just call it that for now. It's called pulmonary edema. There might be also peripheral edema, and so on and so forth. So signs of chronic or congestive heart failure. Then we go on to dermatologic. I guess those are the most obvious. In case the patient has some sort of disease that leads to their blood cells being destroyed, then you might see how blood seeps out of the capillaries and makes its way into the skin to give you ecchymosis or petechiae. Petechiae are smaller than ecchymosis. I guess in dermatology, you will have to be learning this, like in centimeters, how wide a petechiae is versus ecchymosis. Then there's always some sort of pallor, whether it's in the palmar skin or in the conjunctiva. It tells us that there's a decreased hemoglobin in the blood. In the conjunctiva, as you can see, we see it when it's below 90 grams per liter. In the skin, when it's significantly reduced. Question time. Do you guys know how much hemoglobin we have in blood?
Is it 125 to 145 in women and 135 to 155 grams per liter for men?
Yes, well, yeah, that's pretty correct. So we have different values for men and women. Again, the same goes for the hematocrit, which we discussed earlier. The next question is, like, how important do you guys think those boundaries are? You think, like, for example, you said 125?
Yeah, for women.
So let's say like you get a patient, right, and she has 120 and you show her the blood results. Would you say, excuse me, miss, I think that you might be having anemia, so we should check this further?
I mean, if she doesn't have any subjective problems or feelings, or so, I wouldn't do anything, but maybe do like a follow-up to see that it's not continuing to decrease.
Yeah, exactly. So we really care about how the patient feels. We want to ask them, like, do you feel like there's been any sort of changes? We focus on whether the patient reports any changes recently, or if we can see anything, detect anything. Otherwise, it could just be normal. Patients, they come in different sizes and shapes, you know, and everybody has a different story, and in the end will probably require a different treatment. So signs and symptoms, we treat the patient, not the disease. This is like a common saying. Then there might be jaundice as well. Nail changes, you might be hearing about spooning. This is called I think I have it later. I can't really recall right now, but there's a different koilonychia, I think. In medical is a medical term for nail changes or spooning of the nails. It's just they bend upwards. And glossitis can happen, for example, with folate deficiency. Glossitis means that there's some sort of inflammation in the tongue. It might get bigger and more red. You might hear the term beefy red. Then, in some instances, you might get splenomegaly or lymphadenopathy. Now, I want to specify that those signs and symptoms are not specific. As in, like, if you see those signs and symptoms, you can't diagnose the type of anemia that this person has. And in most cases, you just see 1 or 2 or maybe 3 symptoms, but not all. This is another picture of conjunctival pallor. Then anemia, you get to see how it would look like normally versus how it looks like in an anemic patient. I think maybe this is a picture of before and after. And this is like koilonychia, spooning. This is also a pretty late sign. All right, so just some laboratory values that we should know. Most of the time you'll be having like a piece of paper with all the lab results, and in the brackets they'll tell you what the normal lab values are, because it might differ from lab to lab. That's another thing. Like obviously for your exams and in general, you should know more or less how much how much of something should be in the blood, but every lab is a little bit different. So you will be reporting to those values when you will be making a diagnosis. So red blood cell count, it's 10 to the 12. I want to draw your attention to that per liter, 10 to the 12 red blood cells per liter. And the value is somewhere in between 4 to 5. Hemoglobin, we talked about it earlier, male and female different. Hematocrit, again, a little bit different, but around like 50%. This is the volume of the cells measured in cubic micrometers. And this is important. It's 80 to 100. I want you guys to remember just this value, 80 to 100 for now. Red blood cell distribution width in percentage. If you recall, we talked about earlier, like how some red blood cells vary in size from other red blood cells. Well, it's normal if 11 to 15% of your red blood cells vary in size. Reticulocytes were the cells that are precursors to your adult red blood cells, and they make up about less than 1% of the total red blood cells in peripheral blood. One thing to consider before moving on is that you can get anemia chronically or acutely. This is the case with most diseases, though. But it's important because acute anemia can really easily precipitate like severe conditions. You don't have enough time to make up for the losses, right? You're losing blood, for instance, and you don't have enough time to make up or like to generate enough hemoglobin or enough red blood cells to make up for the lost blood. And that's why you'll have a pretty severe clinical picture. A person that's bleeding, is going unconscious, has tachycardia, and so on and so forth. In chronic anemia, there's more time, meaning that the patients are less likely to report symptoms. You just might be seeing them being pale and tired, but they'll be telling you they're fine. Okay, next up is some examples. Like, for example, acute anemia is quite common in younger people, while chronic anemia is more common in older people. And some examples would be like hemorrhage and cancer. Cancer can cause anemia, and it's something that is called anemia of chronic disease, and we'll be talking about it pretty soon. So I think the most important slide for you guys might be this one for third years. For 6th years, I have one at the end, or 6th and 5th years, I have one at the end. So this is how we divide anemias, because, well, first you identify that the patient looks anemic. Then you take a blood sample and you see that the hemoglobin is decreased. Okay, the patient does have anemia, but what kind? You take a smear and look under the microscope, you get to see whether the anemia is microcytic, normocytic, or macrocytic, because the diagnoses are completely different. And so for this, we have to keep in mind the volumes of the red cells. Below 80 is microcytic, above 100 is macrocytic. We mentioned earlier 2 different types of anemia: iron deficiency, producing is microcytic, and then folate or B12 deficiency, producing macrocytic. Normocytic, it just means that the red cells look normal, or they have the normal volume. So a mnemonic for you guys, I don't know if you're the mnemonic kind of people, but TAILS is a pretty good mnemonic, and it refers to thalassemia. Anemia of chronic disease, we said that we can see it with cancer. Iron deficiency, we mentioned it earlier as well. Lead poisoning, not so common nowadays. It was common about 50 years ago when there was lead piping that was running, water was running through lead piping to the houses. Now not so common anymore because of the recognized or the known problems with lead. And sideroblastic anemia is a specific kind of microcytic anemia, not as common as the other 4, and it's described as sideroblastic because of the way that the red blood cells look. And I think I might have a picture later, but just in case I don't. So blast is just a big immature cell, and sidero usually refers to like iron. So there'll be some stippling or like basophils. Sorry, not basophilic, meaning like they color in a specific color. So there's around the nucleus in those big red blood cells some basophilic stippling. I guess in pathology they would like to give it a weird name, such as like salt and pepper. I think this is a totally wrong term, so don't take my word for it. But sideroblastic anemia refers to anemia that looks in a specific way under the microscope. Iron deficiency anemia is, I guess, by far the most common. And before we move on, I'd just like you guys to remember that those are the most important terms when talking about iron deficiency anemia, and they span, physiology, pathophysiology, biochemistry. And so first one is ferroportin. I'll just ask you guys maybe one by one, if you could tell me what they are, what they do, those proteins. You don't have to though, but if anybody, does anybody know what ferroportin is?
I might be mistaken because I'm terrible in biochemistry, but isn't that like the channel or transporter that puts the iron from the epithelial cell into the bloodstream or something? Yeah,
exactly. It's just right here. Porta is like the Latin for gate, ferro for iron, so iron gate. So it's you take basically the iron from within the intestine and you put it in the cell and then outside into the bloodstream. Ferroportin, good. Hepcidin is, I would say, I think it's a hormone, or I would describe it as a hormone. Does anybody know what it does?
It inhibits ferroportin, so the resorption of iron.
Exactly, nice. But is this picture? Yeah, there we go. So hepcidin is actually pretty important. It has to do with like iron deficiency anemia. Also has to do with like the anemia of chronic disease. You can see in the picture that if you have inflammation or iron overload, you upregulate hepcidin. And when you upregulate hepcidin, this signals your enterocytes, macrophages, and hepatocytes to stop taking up iron. So now you can sort of try to make sense of how cancer gives rise to iron deficiency, anemia of chronic deficiency. It causes inflammation. Cancer is commonly associated with inflammation. Then you have upregulated hepcidin, and upregulated hepcidin just means we're taking up less iron. So if we're taking up less iron and you diagnose the patient as having microcytic anemia, probably because of iron deficiency, and you give them iron tablets, they will not be taking it up. It will look weird. Okay. So that was hepcidin. Then we have transferrin. As the name implies, it transfers stuff. Precisely, since we're talking about iron, it transfers iron in between the place where you have it and the place where you need it. Total iron binding capacity, TIBC, is a term that reflects the amount of transferrin that you have in blood. Then transferrin has to bind to something in order to release that iron and give it away basically to the cell. And that thing that it binds to is a receptor, and that's called the soluble transferrin receptor, STFR. It's important to mention those proteins because we'll be using it to diagnose anemias. Then you have ferritin. What is ferritin?
Some form of like storage for iron.
Yeah, that's correct. So iron will be stored attached to this ferritin within the cells. This is kind of like, this is kind of like a stepwise mentioning of terms. First, you get iron, goes through ferroportin. Hepcidin might say yes, you can go in. Hepcidin might say no, you can't go in. Then if iron does get in, it gets bound to transferrin. Transferrin circulates in blood. The total amount of transferrin, TIBC. It might bind to a cell, STFR, and then it leaves the iron in there where it's stored as ferritin. Hemosiderin and haptoglobin. Hemosiderin is basically referring to this protein that has iron attached to it, and it's usually within either subcutaneous tissue or in macrophages. And it might sometimes, like when you get a bruise, that's hemosiderin usually, that bruise, that color. And then haptoglobin is a protein that basically mops up iron from within the bloodstream. Like if a cell has a car accident, if a red cell has a car accident, then haptoglobin will just be the ambulance. Iron deficiency anemia, very briefly, could be because of increased demand, such as pregnancy, decreased supply, such as in celiac disease. So decreased supply means that we're not that's why there's celiac disease in there, means we're not absorbing it really well, or we're just not taking in as much as we want to. This can happen, for instance, with old people suffering from dementia, typically, whether they forget to eat or they forget to take in the proper supplies, they might get iron deficiency anemia. There might be then increased losses acutely occurring with hemorrhage, or like chronically could be occurring with also hemorrhage, but slightly smaller. So for instance, acute iron deficiency anemia could result from, let's say, gastrointestinal bleeding. Let's say that you're an alcoholic for a long time and you're having varices, gastroesophageal varices, and at one unfortunate moment, one of them bursts and you start losing blood, loads of blood actually, you might be getting iron deficiency anemia or any kind of anemia. Any kind, I mean, well, let's just leave it at that because I think I don't want to get into too many details. Let's say you lose a lot of blood, iron deficiency anemia. Chronically, you might be losing very little blood at a time. Everybody knows of menorrhagia, which is bleeding too much, for example, during period. And if you don't make up for the losses with supplementary iron, you might be getting chronic iron deficiency anemia. Or it could also be, once again, a type of cancer. Very, very common here in Czech Republic is the colorectal cancer, so sort of adenoma, adenocarcinoma of the colon, which when it grows, it's more prone to damage. Being more prone to damage, it can get injured and then it loses a little bit of blood before healing again. So some specific signs and symptoms, you have, for example, brittle hair, koilonychia, which we remember that it was the spooning of the fingernails. Pica is a disease where you feel tempted to eat unedible things, meaning that, I don't know, for example, a rubber or cable from, I don't know, I'm just looking at things I have on my desk. Whatever it is here, I would feel like eating it. That's pica. And restless leg syndrome. Those restless leg syndrome, pica, are not so specific, but they can be seen in iron deficiency anemia. I have one case for you guys. I hope you can listen to it. I don't know if it works. Let's check it out. Oh yes, definitely. Can you see the video?
Yes.
And oh, can you hear?
No.
Well, let's see. Basically, there's this one guy, 70 years old, he's tired all the time, no other symptoms, normal examination, hypertension on some drug against hypertension, amlodipine, right? So once again, tired all the time, that's not so specific, but since we're talking about anemias, you can't hear anything, right?
At least not from the video.
Yeah. Okay, so this guy in the video, he like highlights some of the problems that can be seen on his blood test, namely like hemoglobin being 92. This is significantly decreased. If it was like 110, I'd be like, okay, he's old, he's 70 years old, right? That's all right. But it's 92, that's kind of suspicious. MCV, very suspicious now, of microcytic anemia. So let's see what he does next. What could cause this? He asked the questions. Well, we talked about it earlier, tails, right? Iron deficiency, thalassemia, anemia of chronic disease, and then it was also sideroblastic anemia. So we have this differential diagnosis in mind. We move on. We start measuring. Different things. Ferritin is one of the most important things to be measuring because ferritin will show us how much iron he has. So for instance, in iron deficiency anemia, ferritin would be decreased, right? CRP, we might be measuring CRP because we're interested to see if the patient has some sort of inflammation. Inflammation being linked with anemia of chronic disease. So in the end, they figure out that ferritin is very low, CRP decreased. It definitely has to be then like iron deficiency anemia. I'll be putting up this lecture online later, or I think MIMSA will be, and you guys can watch the other clinical cases. I have some that are like YouTube form and then others that are written down. So this was microcytic anemia, so thalassemia, anemia of chronic disease, iron deficiency, lead poisoning, sideroblastic. Definitely the most common one is iron deficiency. Again, thalassemia, does anybody know what it is? All right, so thalassemia is a genetic disease. It could be either alpha or beta. It's more common in the Mediterranean area and also in Asia. This genetic disease results in a bad globin molecule, meaning that the patients are more prone to anemia. There's different types, beta and alpha, depending on which part of the globin molecule, which subunit is affected. I don't know which one is more common, but both of them are treated similarly. And that is with that is symptomatic with regular replenishment of blood, so blood transfusion. Just to clarify a little bit what thalassemia is, but definitely I want you guys to remember from microcytic anemia as iron deficiency, because it is by far the most common. So moving on to normocytic anemia, this is all the anemias where the red blood cells look more or less normal. And it could be due to acute blood loss, according to this mnemonic ABCD. Also, I have another mnemonic. Those are all taken from the Toronto Notes, which is the book that I used to prepare for this lecture or seminar. And you guys will have a link to the Toronto Notes, how to get it at the end of it. Right, so they're using those mnemonics. So for the first one was tails, this one has ABCD, and macrocytic anemias has ABCDE. The most useful one for me was tails. So normocytic anemia, ABCD, we go acute blood loss, bone marrow failure. We talked about this at the very beginning. Again, chronic disease. As you can see, chronic anemia of chronic disease could be sort of all over the place. It's not like a static picture. And then destruction, meaning hemolysis. Maybe the most outstanding type of normocytic anemia is hemolytic anemia. And this is what I'll be focusing on.
Excuse me.
Yeah?
One thing, Andrei, thank you so much for the lecture. I have another call at 6, so I have to leave, but I'm really sorry. But will you put up this presentation somewhere so I can like go through that?
Yeah, this I think will be on YouTube at the end.
Okay, great. Thank you, and have a good weekend. Happy Easter.
Yeah, cheers. All right, yeah, so in normocytic anemia, this is, since we're talking about differential diagnosis, well, we have to divide this normocytic anemia into two to make our life a little bit easier. And so if we have increased destruction of red cells, then we have to see some sort of signs that our body is trying to respond by making more. And that sign will be increased reticulocytes, which was the precursor to red blood cells. So more of these will be seen in the red blood, in the peripheral blood, in case there's increased destruction of cells and everything else is normal, namely bone marrow. When the bone marrow isn't doing well, reticulocytes are also decreased besides the red blood cells, which are decreased. And that could possibly be the result of like a pancytopenia, bone marrow damage. And you see not only anemia, but also other problems, such as neutropenia. Patients are more likely to get infections and so on and so forth. So hemolytic anemias. How are you guys doing? Are you okay?
I'm okay.
Yeah? All
Yeah.
right. Just checking with you. So hemolytic anemias are pretty difficult, and that's why I want to go through them with you. They're also relatively common. And they can be, the more categories you have in the end, I guess it does seem like it's a lot, but it makes it slightly easier to learn than just a list of different etiologies. So that's why we're breaking it up in so many different categories. So normocytic anemia, subtype is hemolytic anemia. Hemolytic anemia, the etiology is either inherited or acquired. Remember at the beginning we talked about flexibility? Well, in case you have an inherited condition, such as sickle cell anemia, this will go under hemoglobinopathies, right? As in, like, there's a problem with our hemoglobin molecule, and it will make it less flexible. Therefore, we're more likely to get hemolysis. We could have abnormal enzymes. In particular, you'll see frequently mentioned this one enzyme. Well, let's see if I can. There's this one enzyme that I want to be writing it down for you guys. It's called 6-glucose phosphate dehydrogenase. So this goes here. What it does is that when you have enough of it, enough 6-glucose phosphate dehydrogenase, you can produce enough antioxidants, in particular glutathione. Yeah, so those two, they go hand in hand. 6-GPD with glutathione is right here, abnormal enzymes. And if you can't produce antioxidants, namely glutathione, then the cells are more likely to suffer from free radical damage, right? And if they do suffer from free radical damage, they sort of explode. Well, it's not that dramatic as they make it seem like, but let's just call it explode, and you get anemia. With 6-glucose phosphate dehydrogenase deficiency, the anemia is not chronic, it's more acute, because there's usually some sort of triggers. Like, for example, let's say you eat fava beans, right? So that's very commonly listed in textbooks. So this triad, everybody likes to have a triad. So this will be like Andrei's triad. So fava beans, right? So those three, they go together, right? They're over here at abnormal enzymes. 6-glucose phosphate dehydrogenase deficiency, glutathione, fava beans. You eat fava beans, you have this problem, and your red blood cells explode. So again, an acute episode of hemolytic anemia, inherited condition. Another inherited condition would be an abnormal membrane, particularly spherocytosis or elliptocytosis. You might be hearing about this frequently. I don't know about the incidence, but I'm to some degree convinced that inherited hemolytic anemias are not as common as the acquired ones. Right, so then we move on to acquired, which are more common. So I guess if you choose to remember something from this slide, maybe remember those acquired hemolytic anemias, and we divide them into microangiopathic and macroangiopathic. Why this you don't usually find in the textbook, so you like, hopefully you will remember it forever. Microangiopathic and macroangiopathic, or you do find in the textbook, but it's not classified as such. Micro because it happens in capillaries, macro because it happens in the big red blood cells. All right. So to mention briefly, like, macroangiopathic anemia happens, for example, in, let's just say people that have extensive atherosclerosis or people that have an artificial heart valve. I think I have a slide for it later. Yeah, so do you see the slide? Do you see the atherosclerosis in the vessel wall? Well, imagine that this could be anything. And the red blood cells, they're just chilling, you know, they're floating away basically. And then all of a sudden there's this, you know, usually I like to give those examples with car accidents. So let's imagine you have like this car and all of a sudden there's a roundabout and you don't see it and bang, you crash. And then your cells kind of get bumped up, they explode, whatever. Cool movies. So imagine now that you have this patient, he has a heart problem, you replace the heart valve. The heart valve is not like the new heart valve is not like the new, the ones that you normally have. They're sort of stronger, could be metal or other hard materials, and those red blood cells, they come by, they pass by, and then they can get damaged. Therefore, you get hemolysis. So that's macroangiopathic anemia, right? Or they go past the big blood clot. There's a big mess going on there, and again, they collide. Microangiopathic anemias, they usually happen in capillaries. So that's the difference that they might want to hear here at Masaryk University. Okay, so
a question.
Yeah.
So in macroangiopathic acquired hemolytic anemia, will this be like a progressive, like worsening of the anemia, or will it be like one day you have a new heart valve and the second you are anemic?
I don't have enough clinical experience to precisely tell you the answer to that, but an educated guess of mine would be that it's rather chronic, that it steadily happens. Like you don't have acute episodes, but it just happens over time. And if your bone marrow is okay, then you're making up for everything you lost. So it's some sort of like stable chronic hemolytic anemia. But this is just my educated guess.
Okay, thank you.
Moving on, right, so we have the etiology, which can be divided into inherited and acquired. Am I going at the right speed? Am I going too slow, too fast? What do you guys think? Is anybody left?
I think it's okay.
Continue.
All right. So, right, hemolytic anemias, we have intravascular. They can be divided into intravascular or extravascular. This is a more clinical classification. Intravascular means it happens within vessels, and extravascular, it means it happens somewhere in the reticular endothelial system. There's two big organs that make up the reticular endothelial system. Namely, you have spleen and liver. But when you have hemolytic anemia and extravascular hemolysis, usually happens in the spleen. And the reason I'm putting this classification up as well is because, well, if you have intravascular hemolytic anemia, the cause is, but not always, usually non-immune. Non-immune meaning that there's no antibodies involved or no complement involved. And this is usually the case, but not all the time. If it's extravascular, it means the red blood cells are usually tagged by some sort of antibodies, and you have macrophages in the spleen, and they kind of like pick up or they pick on the tagged red blood cells. You know, it's kind of like people with, let's say you just have like a person with COVID, right? You'll pick on them to put them in the hospital. That's a pretty bad analogy, but whatever, you kind of get the picture, hopefully. So to move on, this is I'm sorry guys, there's not many pictures in this like hemato-onco, but let's see. Here I'm mentioning briefly elliptocytosis and spherocytosis, which I said earlier that they're inherited conditions of normal membrane. In elliptocytosis, the red blood cells are sort of elliptical, as you can see here. In spherocytosis, the red blood cells are relatively spherical, and that just makes them a little bit more prone to damage, meaning that the lifespan is decreased. Another picture, schistocytes is a type of cell that looks just like this on the blood smear. It's important because if you see a schistocyte in the blood film under the microscope, that will tell you that some sort of hemolysis is going on, that the red blood cells are getting damaged. Right, so then if that happens, usually there's a lot of hemoglobin being released, and therefore the patient will be jaundiced. There's an increased load of hemoglobin on the liver. It can't process that much hemoglobin. Therefore, you will have unconjugated hemoglobin showing up in the skin, sclera, and so on. Then you have sickle cell anemia. We talked about this a little bit earlier as well. It was an inherited condition that leads to the sickling of red blood cells. Sickling simply stands for the fact that the red blood cells acquire this sickle-like shape. The hemoglobin molecules, they just, when there's not enough oxygen, they basically get stuck to each other within the cell, and they kind of pull out the red blood cells. They pull the red blood cell out of its shape. It's basically like putting a stick within a balloon, and then the consequences of that. So now, maybe this will be like a little bit too much for everybody, but microangiopathic hemolytic anemia, I mentioned it a little bit early. Macroangiopathic was the one when you have like a new heart valve, right? And so that's pretty easy to memorize, to remember. But then the other one is microangiopathic. So when does the red blood cell undergo hemolysis in the periphery? So this could be an immune cause or non-immune. If it's immune, then it could be auto or allo. Allo just stands for something that doesn't belong to you. Auto, it means your immune system is attacking your own red blood cells. And there's two different types of autoimmune hemolytic anemia. Namely, you have the worm autoimmune hemolytic anemia. So W stands for worm, C stands for cold. Worm is the more common one, and I'm mostly mentioning it because they can be seen in the context of a cancer, right? Next up, you have non-immune, and here there's two classes, namely thrombotic microangiopathy. I'm just gonna put it down here. So thrombotic microangiopathy. This is not one type of anemia, but this is not one diagnosis. It's rather like a syndrome, a group of diagnoses. And TMA is the term we use nowadays. MAHA, or microangiopathic hemolytic anemia, was the term that was used previously. And then also another cause of non-immune is infection. So you have, for example, like malaria, which is a parasite that specifically infects red blood cells. and then that leads to hemolysis. You guys probably know there's like this malaria can be, depending on the type of parasite or the subtype of parasite, can be divided into malaria quartana, which means that you get like fever every 4 days, or there's, I think, malaria tertiana, where you get fever every 3 days. Basically, why I'm mentioning this is because like it just reflects episodes of acute hemolysis, right? So once again, this is microangiopathic hemolytic anemias. They occur in capillaries. And why does that happen? Well, either there's some sort of antibody that is upset with our red blood cells and is attacking them, or there's some sort of either parasite or this dubious TMA that we'll be talking about it later. What kind of anemia is microangiopathic hemolytic anemia? It's a normocytic anemia under the category of hemolytic anemias. It's acquired and it's microangiopathic. And in the bloodstream, you see increased reticulocytes because the bone marrow is okay and it's trying to make up for the losses. So once again, we're back to this slide. Intravascular hemolysis. We mentioned microangiopathic hemolytic anemias. Well, in microangiopathic hemolytic anemias, the system is, or like the mechanism is pretty similar. Bang, crash, and then destroyed. So as I said before, this TMA, thrombotic microangiopathy, is actually like a group of diseases. I know this is a lot, but in case of different, like, it's pretty much necessary to be aware of most of those conditions, as patients, you know, they don't really choose exactly what they have, they just get it. And it's up to us to identify what it is. So TMA, thrombotic microangiopathy, also known as microangiopathic hemolytic anemia. I'll just briefly go through it. Forget about primary and secondary. This is just a nice picture that you can be using later on for your studies. So infection-induced, HUS, hemolytic uremic syndrome, could lead to clot formation. Atypical hemolytic uremic syndrome is similar to infection-induced, leads to clot formation, and again, you have this picture where kind of like red blood cells are destroyed within the blood vessels. Another type of thrombotic microangiopathy, you have it in the name, thrombotic, as in like you have a clot formation here, and then the red blood cells sort of as they pass by. Sorry, I really like use this slide a lot, but as they pass by, they get destroyed. So you have it in the name, thrombotic microangiopathy. If you remember the other one, microangiopathic hemolytic anemia, you also know where it happens. So why do you get blood clots? Well, hemolytic uremic syndrome, atypical hemolytic uremic syndrome, and thrombotic TTP, thrombotic thrombocytopenic purpura. This is not part of today's lecture because this has to do with platelets. So TTP stands for thrombotic thrombocytopenic purpura. Thrombotic because you have thrombus formation, and if you have thrombus formation, the red blood cells that pass by, they get hemolyzed, so anemia occurs here. This is part of, would be part of a different lecture. Purpura is just bleeding in the subcutaneous tissue, and the thrombocytopenic refers to decreased platelets. Other reasons include pregnancy, precisely the HELP syndrome, preeclampsia. Okay, this is maybe too high yield, or malignant hypertension. This is when you have way too high blood pressure, and so it doesn't matter whether you have irregularities in the bloodstream or not. The red cells will travel at such high speed that they will crash and get damaged. Some other miscellaneous ones like disseminated intravascular coagulopathy is another important mention. So once again, HUS, if I were to mention the most important ones of TMA, be HUS, TTP, DIC, and HELP. All right, so this is quite a lot, but you guys can do it. I can do it. We can all do it. We can make it. All right, now I had I think Tim was it earlier. Now he's gone. He mentioned that pancytopenia is just when you have an ineffective bone marrow. So that's a deficiency of cells from all lineages. Red blood cells, white blood cells, megakaryocytes. So let's go really quick through it. It could be inherited or acquired. If it's inherited, it's most probably Fanconi anemia. This is a gene defect that leads to cells within the bone marrow to be easier to so in Fanconi anemia, basically there's a gene defect that will stop your DNA from being repaired, and whenever you get DNA damage, the cell will rather choose to to self-destruct rather than carry the damaged DNA, and that will be Fanconi anemia. It's important to differentiate Fanconi anemia from Fanconi syndrome. It's completely different, and you can easily mix it up, which is why I'm mentioning it here. Please don't mix it up. Fanconi, this is anemia. It causes pancytopenia. Fanconi syndrome is like, it has to do with the kidney. Let's see. I really wanted to introduce this here. So Fanconi syndrome right here, you have the kidney, right? So don't mix it up, or obviously it might happen. Please just try to avoid it. Others, so acquired, when can you get a deficiency in all cell lineages? Well, when you have chemotherapy or radiotherapy that will attack your bone marrow. Toxins such as benzene. So whenever you think of benzene nowadays, think of iPhone and Android as well. They're making those products and other electronics with benzene. So those people will probably get, like, besides pancytopenia, also cancers of the bone marrow and so on and so forth. Infections, viral, some virus can make its way to the bone marrow, infect your cells, and then you get something that's called pancytopenia. Others would be paroxysmal nocturnal hemoglobinuria. This would be somewhere here with Fanconi anemia. It's also, I think it's also an acquired gene defect, but I'm not so sure, so I prefer not to tell or like talk too much about it. So we're reaching closely to the end. This was the hardest part, I guess. The hemolytic anemias was pretty much a lot. A quick quiz. Which one of the following red blood cells indices tells you how big your patient's cells are? And well, since probably everybody is like relatively tired, I'll go quickly through it. So which of the following red blood cells indices tells you how big your patient's cells are? It's MCV. And why do you look at MCV, and why is this question so important? Because MCV will help you classify your anemias. It's the most important thing probably in this whole presentation. RDW stands for red blood cell distribution width, and it measures what? The variation. Oh,
Yeah,
nice.
I'm still awake. variation in red blood cells?
Okay. So then can you do me a solid and answer this next question as well?
Ferritin.
Nice. Wait, I haven't read the question. What is the measurement? So yeah, correct. That's ferritin. Right, so you pretty much learned the most important things in this lecture. So the last one was macrocytic anemias, A, B, C, D, E, F. It's just a mnemonic. I personally did not use it because I find this slide more useful. We divide it into megaloblastic. We talked in the first slide, the big cells, and this is far more common, or I would say, yeah, more common than non-megaloblastic. So megaloblastic just means that you have huge cells, and there's increased. I mean, there's the DNA synthesis is relatively blocked or absolutely blocked because you don't have enough B12 and or folate. So B12 or folate deficiency can lead to megaloblastic anemia. Another thing that can lead to megaloblastic anemia is antimetabolite chemotherapy. Means you just give them some, this is typically patients with cancer, right? You give them antimetabolites. So for example, you have methotrexate. It's a pretty common drug used to treat a bunch of other conditions as well. Methotrexate. You give it to your patient, and yeah, it does affect the cancer cells, but also it produces anemia. And then non-megaloblastic could be a series of conditions that cause this non-megaloblastic macrocytic anemia, namely alcoholism, liver disease. This go hand in hand, alcoholism and liver disease. Then hypothyroidism as well. And then finally, myeloproliferative syndromes. This is like leukemias, cancers of the blood, and MDS, myelodysplastic syndrome. It just yields dysplastic cells with abnormal nuclei and inefficient production or inefficient maturation. Yeah?
In this antimetabolite chemotherapy, how would one treat the anemia? Just like supplement packed blood?
Well, you can provide them with red blood cells in transfusion, which is like, I don't know if it's the easiest way. You can also provide them, there's a drug that is called granulocyte. Well, but I don't think you would be using that. You can provide them with EPO, which is the hormone.
Yeah.
But this is more of a, it's not really my specialty, and I can't really say I studied it extensively. There's multiple approaches, but I guess in the end, you kind of, it's a really difficult decision, you know, and it's rather for oncologists, you know, they'll have to, you know, balance sort of how the patient feels with how is their cancer doing. And the question is like, are we going to continue giving him antimetabolites? Are we going to switch it to a different drug? It's rather up to discussion, I would say, because it's very individual. But basically, yeah, you can use some sort of red blood cells in a packed red blood cells in a transfusion, right? Yeah, it's just very basic knowledge that I have there. All right. Yeah, so maybe you want to consider like changing the drug as well. But once again, right, better consult a professional. So just quickly, B12 and folate deficiency, like you mentioned at the very beginning, it could be due to a bad diet. vegans, they they're more prone to getting B12 deficiency because they are unaware that, or rather that they have a poorly planned diet, and it can be easily fixed with supplements, right? You have a 3-year, 2-year worth of B12 in your body, so veganism usually may produce megaloblastic anemia after about 2 to 3 years. They could be gastric or intestinal, because we know that, for example, if you see in this picture, B12 is initially ingested, for example, attached to, or it's like commonly ingested, it's part of like the red meat or any kind of meat actually. Here it's bound to intrinsic factors, and bound to intrinsic factors, it travels distally to the ileum, and here it's absorbed. So in case, for example, you're not producing enough intrinsic factor, such as it occurs in this genetic condition of intrinsic factor deficiency, or the parietal cells, which are the ones secreting intrinsic factors, are damaged, you also get the lack of intrinsic factor, therefore decreased absorption of B12, and in the end you get B12 deficiency. Intestinal, anything that produces malabsorption, so like, for example, celiac disease. All right, in this picture we are looking at neutrophils. In the first picture we have normal looking neutrophils, and in the next picture we have hypersegmented neutrophils. And you might be asking, why the hell are we looking at neutrophils right now? But the reason is, you see, B12 and folate, they're involved in DNA synthesis. So it's not going to only affect red blood cells, but it also affects other cell lineages. And one of the things you might be seeing in the blood film is this hypersegmented neutrophils. All right, just quickly, we're approaching the end. Common lab findings in anemia patients. At the very beginning, all types of anemia, decreased hemoglobin, decreased RBC count. If it's decreased MCV, you get microcytic anemias. If it's increased MCV, macrocytic anemias. And then here you might be seeing something like decreased ferritin in case of iron deficiency anemia, or increased ferritin, for example, in chronic disease. Because in case you have chronic disease, you're not lacking iron, you actually have too much, it's just you can't really use it because of the hepcidin hormone. In hemolytic anemias, there might be increased bilirubin and increased LDH. LDH is lactate dehydrogenase. It's an enzyme that could be used as a marker of inflammation. And this is like commonly elevated in hemolytic anemias. And one important thing that I want to remind you of is the Coombs test, which is something that we might be using to diagnose extravascular hemolytic anemias. And it's performed quite commonly in the laboratory. It's quite easy. So it could be direct or indirect. And I'm mentioning here like two different indications to use the direct one. So for example, autoimmune hemolytic anemia, or indirect would be in blood cross-matching. In case you want to like do some sort of transfusion, you might be doing Coombs test before you do that to make sure that there's no cross reaction. So what does Coombs test do? It identifies basically antibodies against your red blood cells. Direct one, it identifies red blood cells that have those antibodies stuck to them. And then indirect one, it identifies antibodies, and that's it. So direct Coombs test, it looks at cells. Indirect Coombs test, it looks at antibodies. And I just have this nice pictures right here. So direct Coombs test, you take a blood sample from the patient. You have those nice antibodies that are marking those cells for destruction, and we want to diagnose that this is the case. We do the direct Coombs test, meaning we take a solution of our own antibodies, meaning that something that we prepared, and when we add it to the patient's blood, we get this picture right here of agglutination, because our antibodies have bound together all the red blood cells and the antibodies attached to them. And now we have agglutinates, and that's the direct antiglobulin test or direct Coombs test. Then there is also the indirect Coombs test. This is used, as I said before, in case you want to do a cross-matching. And in here, we just take the serum. This time, we don't take the blood. We take the serum from the patient. We put a little bit of donor blood to have some red blood cells. So this is, let's just say that I need a transfusion, right? And there's, for example, I don't know, Rico here, that wants to give me blood. They will take my blood, separate it, get the serum. In the serum, there's antibodies. They will take a sample of her blood, and then so basically they will separate the red blood cells, add it to the serum. If I have antibodies against those red blood cells, they would get bound, but nothing would happen at this moment. Then we add a little bit of the antibodies we produced in the lab, and then we get agglutination if she's a no match. All right, and that would be it. And we have some clinical cases here. Should I go through it? What do you guys think? Is anybody still awake, alive?
Like, we can do one, I guess. I mean,
it depends on your time, because look, there's 4 people left. So if you don't want to do it, then that's all right with me. What do you think?
Plan for today.
Okay, so you want to go through one?
Yeah.
All right, so let's say you have this 40-year-old female, and she says she feels tired all the time, right? You do a physical exam, and you see that she has what? Tachycardia, and she's pale. So that's pretty weird. You order a complete blood count. I mean, yeah, you do suspect anemia, but you ordered a complete blood count anyway. If the patient feels unwell, that's the first thing you do, complete blood count. And you get to see what? Hemoglobin is 100 and MCV is 75. Reticulocyte count is not increased. So reticulocytes, predecessors of red blood cells, if the bone marrow is trying to make up for destroyed red blood cells, and it can because it has enough supplies of everything, then this will be increased. Mm-hmm. So what do you think is the most likely cause right here?
Okay, since I have time and I'm the only one, it's like my time to shine. I will like explain what I don't think it is. So I don't think it's megaloblastic because the MCV is decreased, so it's micro.
Nice.
Then because of the not increased reticulocytes, I don't think it will be hemolytic, because otherwise it would be increased because the body wants to compensate for it. So iron deficiency anemia is like left.
Nice, good job. I mean, if this was in person, I'd probably give you some candy. But I can give you like some applause. I don't know.
I take that. Thank you.
Now this awkward moment will be forever on the internet. So this at the end is just how it all looks like when you put it together. And I guess for your exam in pathophys, just looking at this and knowing that this is the way we classify them is the best thing ever. I had a difficult time, back in third year. I didn't really know where to get the information from, and then when I did get the information, it was too much. Here you have references. For everybody, I recommend opening up this link. I'll be sharing the presentation later on. I think they'll be putting it up online. So you click on this link, it'll take you to like that picture that I showed you at the very beginning, this picture right here. Looking at it, you'll learn about hemoglobin, bilirubin, and jaundice. 5th and 6th years watching this, I recommend you look at Toronto Notes 2018. There's also a link right here that you can click on. It'll take you to where to get it. And others, this is just other references that I used. If you want to study further, this is what I recommend for everybody. There's this one guy on YouTube, Medicosis Perfectionalis. I found him to be really good when it comes to, well, almost everything from basics all the way to the more complicated stuff. And for 5th years, or even 4th years, I recommend the Oxford Handbook of Clinical Medicine. I tried to get it from the 3rd year. It's good if you have time to read it, but I didn't really manage.